Welcome back, everyone, to Part 93 of the Masterclass. I am absolutely thrilled to have you here for today's explainer. Now, last time, in Part 92, we tackled the heavy complexities of orthopedic surgery and major joint replacements. But today we are taking an advanced medical DRG deep dive into major diagnostic categories 09. We're looking at diseases and disorders of the skin, subcutaneous tissue, and breast. This is an incredibly critical area. We're covering everything from severe soft tissue infections to complex reconstructive surgeries. The coding nuances here are literally vital for accurate reimbursement. So grab your notebooks because we've got a lot of ground to cover.
But real quick, before we get too deep into the clinical weeds, I just have to remind you, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is exactly what keeps these masterclasses free and accessible for everyone trying to conquer the inpatient DRG system. Okay, let's dive into this. Here is our roadmap for today. First, structural partitioning. Second, ulcers and soft tissue infections. Third, breast procedures and reconstruction. Fourth, high-yield CDI and compliance. And finally, number 5, our summary and teaser.
Section 1. Structural partitioning, medical versus surgical logic.
All right, we need to understand the overarching architecture of MDC09 right out of the gate. How does the system categorize a patient's stay from the moment you start abstracting the chart? Well, every single case falls into one of two buckets. On one side, we've got the medical partition, which was actually going to be a huge focus for us today. This bucket includes patients admitted for things like aggressive IV antibiotics, severe dermatosis management, or intense wound care. Think MRSA cellulitis, stage 4 pressure ulcers, or non-operative breast malignancies. But on the flip side, we have the surgical partition, the exact moment a physician performs a significant operating room procedure, like an excision of a major skin lesion, a mastectomy, or a complex reconstruction like a tram flap. Boom, the DRG grouping logic completely shifts. And the surgical partition generally carries a much higher relative weight, which dramatically impacts the final hospital payment.
Now check this out. Notice how the ICD-10 PCS strictly defines surgical root operations. It is so easy to mix these up if you're not careful. Take excision versus resection. If a surgeon removes just a small portion of a body part, say excising a skin lesion or doing a breast lumpectomy, that is an excision. But if they remove the entire body part, like a total mastectomy, that root operation is a resection. As coders, we must meticulously read that operative report. If you mistakenly code a resection when it was actually only an excision, you are practically inviting a massive compliance audit and a denied claim.
Section 2. Ulcers and soft tissue infections.
Moving right along, let's transition into some of the absolute highest volume medical DRG concepts you're going to encounter: complex chronic wound care, localized infections, and severe dermatoses. You absolutely have to distinguish between true pressure injuries and non-pressure ulcers. Things like moisture-associated skin damage, or MASD, and incontinence dermatitis map to completely different coding pathways. Pressure ulcers, which you probably know as bed sores, are caused by prolonged pressure. That's usually over bony prominences in patients confined to a bed or wheelchair. Non-pressure ulcers, on the other hand, are driven by underlying systemic issues or environmental factors. We're talking poor circulation, diabetic neuropathy, or excessive moisture. A diabetic foot ulcer is not a pressure ulcer, and confusing the two will lead to immediate DRG mismatches.
And this brilliantly illustrates why connecting the dots is so crucial for accurately capturing the severity of illness. If a patient comes in with a diabetic foot ulcer with osteomyelitis, you can't just code those as totally isolated events. No way. You must use combination codes and establish clear cause and effect linkages to show the complex clinical picture. This linkage is exactly what proves to the payer why your patient needed an extended hospital stay, intense IV therapy, and rigorous wound care.
Let's walk through a super common, real-world scenario of how this builds when a patient's condition changes during their stay. Imagine a patient is admitted with a stage 3 pressure ulcer. During the hospitalization, unfortunately, the ulcer worsens. It progresses to a stage 4. So how do we code this? Well, you actually code both. You report the stage 3 ulcer with a present on admission, or POA, indicator of Y. Then you report the stage 4 ulcer with a POA indicator of N, because, simply put, it wasn't there when they walked through the door. This is critical. That stage 4 ulcer is now a hospital-acquired condition, an HAC, and that POA flag tells the DRG grouper not to increase the payment for it.
These soft tissue issues don't just stay local. They are major triggers for systemic illness. What are the common localized infection sources that can quickly spiral into sepsis? We're looking at cellulitis, abscesses, underlying osteomyelitis hidden deep in stage 4 ulcers, infected pressure ulcers, and surgical site infections. If your patient has sepsis triggered by cellulitis, maybe it's driven by a specific organism like MRSA or group A strep, sepsis is your principal diagnosis. The localized cellulitis with the identified organism is then sequenced as the secondary diagnosis. You always want to anchor the localized infection to the systemic response.
Section 3. Breast procedures and reconstruction.
Okay, let's pivot over to the surgical partition, because the PCS manual has some very strict rules here. You've got to pay close attention to your operative notes for biopsies. A core needle biopsy, which literally cuts a core of tissue from the breast, goes to the root operation excision. But a fine needle aspiration, which just pulls or strips out fluid or cells, goes to extraction. Now here is a massive guideline you definitely want to remember. If a diagnostic excision, like a biopsy, is followed by a therapeutic partial mastectomy at the exact same procedure site during the same operative episode, you only code the therapeutic partial mastectomy.
Now, let's talk about reconstruction. Specifically, the transverse rectus abdominis myocutaneous flap, better known as the tram flap. This is an incredible procedure that often follows a mastectomy. As a coder, you need to verify some very specific elements in the op report. You're looking for the harvesting of skin, fat, and the rectus abdominis muscle from the lower abdomen. You need to see documentation showing that the blood supply was preserved, typically via the superior epigastric artery, and that this whole tissue complex was transposed to recreate the natural breast mound. Capturing the deepest tissue layer in the flap, which is the muscle, is the absolute key to accurate PCS coding here.
And hey, don't overlook the non-invasive side of things. These procedures are often associated with intense medical wound care. In the IC10 PCS placement section, you're going to find codes for putting pressure on a body region, like applying a pressure dressing to an abdominal wound. That actually falls under the root operation compression. Now, if the material is just there for protection, it's dressing. These are so easily overlooked, but they are essential parts of the patient's comprehensive clinical picture.
Section 4. High-yield CDI and compliance.
All right, team, let's get into the real bread and butter of defending your charts: clinical documentation integrity, or CDI, and compliance. This is where we ensure our documentation is bulletproof against aggressive payer audits. So, the crucial point here is that specificity drives accurate reimbursement. Just look at this comparison on the screen. If a provider writes wound infection, well, that's incredibly vague. It yields an unspecified code, lowers your DRG weight, and basically rolls out the red carpet for audits. Now, compare that to post-procedural surgical site infection of the sternum due to Staph aureus. Wow, that specific documentation gives you the exact anatomy, the clear cause and effect relationship, and the specific organism. This is exactly what we mean by codable and query-proof documentation. We also have to be absolutely relentless about our present on admission or POA flags. Why? Because this heavily dictates hospital revenue and potential CMS penalties. I touched on this earlier with the pressure ulcers. A Y means the condition was present on admission and can act as a complication or comorbidity to actually increase the DRG weight. An N means it's a hospital-acquired condition. Think catheter-associated UTI or a brand new DVT. CMS is absolutely not going to pay you extra for conditions that develop under the hospital's watch. And if the documentation is insufficient, a U, that is your automatic trigger to send a CDI query to the provider. You have to protect both the revenue and the clinical accuracy.
So what does this all mean for your queries? How do you craft a compliant one? Well, if you see wound infection in the chart, you cannot just lead the physician to a higher-paying code. A compliant query has to present all clinically reasonable options based on the chart's actual clinical indicators, like lab results or wound cultures. You ask them to clarify the site, the organism, the acuity, or to differentiate a standard infection from a necrotizing soft tissue infection. And critically, you must always include the option for Other Please Specify as well as No Change to Current Documentation.
Section 5. Summary and teaser.
Wow, we have covered some seriously intense, high-yield material today. Let's bring all these concepts together to really solidify the lesson before we wrap up. Here are your masterclass key takeaways. First, clinically distinguish true pressure injuries from non-pressure vascular ulcers, or MASD. Second, you have to master those POA sequencing rules for progressing ulcer stages. Remember our stage 3 to stage 4 scenario? Third, on the surgical side, know your root operations inside and out. differentiate an extraction, FNA biopsy from an excision, core biopsy. And finally, always anchor your secondary diagnoses, like severe sepsis or osteomyelitis, to the primary localized infection with crystal clear cause and effect linkage.
And if you thought today was deep, just wait until next time. Coming up next in Part 94, we are doing an advanced surgical DRG deep dive. We're going to be unpacking complex skin debridement, extensive mastectomies, and even more advanced reconstructive coding scenarios within this same diagnostic category. It's going to be great.
Once again, thank you so much for your dedication to mastering inpatient coding. If you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
I'm going to leave you with a provocative thought as you head back to your charts today. Are your clinical queries truly query-proof, or are you leaving critical severity data, like specific organisms in cellulitis, accurate ulcer staging, and clear clinical linkages, undocumented and completely vulnerable to audits? Challenge yourself today to look just a little deeper into those clinical indicators. Keep coding accurately, keep defending the revenue, and I will see you right back here for Part 94.